Yes, yes, we can hear you.
Okay, share your screen. Hello,
Right.
welcome back. Can you share your screen with us and present?
Yes, yes.
Start.
I'm just putting the PowerPoint. So we'll start with the solo, with the solo presentation.
Yes, please.
Can you see my screen now?
Yes.
Okay, so again, I'm Dr. Inna Tasturi. I will be presenting today some causes of, some hormonal causes of bradycardia. To be honest, it was quite laborious to find some causes in plural, hormonal causes of bradycardia, not just metabolic causes, hormonal particularly. So I thought I could start with something quite easy, quite common, hypothyroidism. Bradycardia is quite common in such a condition. It can also be seen in panhypopituitarism, where we have hypothyroidism as well. It could cause sinus bradycardia, sick sinus syndrome, or AVG disturbances. And the mechanisms could be low levels of thyroid hormones, or in some in some studies, myocardial mucoid degeneration. The second cause that I would be talking about is hyperthyroidism. Usually with hyperthyroidism, we have tachycardia, atrial fibrillation, atrial flutter, etc. But and bradycardia is a rare phenomenon in such a condition. But it has been described since the 1970s. Sick sinus syndrome confirmed with electrophysiological study, complete heart block in thyrotoxicosis, and these conditions in these studies have regressed after correct antithyroid treatment. So we're not sure about the mechanisms. Again, we're not sure about the mechanisms, but it has been suggested that the autoimmune mechanisms that touch the thyroid in Graves' disease particularly might affect the myocardium and the conduction system. So the next cause that I would be talking about is pheochromocytoma. Usually it's also associated, just like hyperthyroidism, to tachycardia and atrial fibrillation, etc. But on the studies, almost 10%, there is a rate and prevalence of 10% of bradycardia in pheochromocytoma. And so it's not that common, it's quite uncommon, but it's there, it's described in the literature. And it's thought to be due to a vagal increase after a baroreceptor activation due to high blood pressure, that is due to epinephrine release, adrenaline and noradrenaline release. So pheochromocytoma, adrenaline, noradrenaline release, high blood pressure, carotid baroreceptor activation, and increase in vagal tone, so bradycardia. The next cause I'd be talking about is acromegaly. And to be honest, I found some case reports of acromegaly, high-grade heart blocks or sick sinus syndrome in acromegaly, but these are just case reports. There is no identified mechanism where we could say this is a mechanism of heart blocks and bradycardia in acromegaly, but there are some hypotheses about myocardial fibrosis and interstitial myocardial fibrosis and cardiac hypertrophy causing these bradycardias. The last cause I will be talking about is adrenal insufficiency. And this is actually, again, I found some case reports, some sporadic case reports, and it's an indirect cause of bradycardia due to hyperkalemia. So aldosterone hyperkalemia, a decrease in the excretion, renal excretion of potassium, high potassium levels, bradycardia. So it's not really hormonal cause. It's not the hormones that are causing the bradycardia, but the consequences of the hormones. So that would be it for me. Hope it wasn't too long. I'm sure it wasn't. It was even quite short. Let me know what you think.
Thank you. That was very, very extensively explanation for the. Let's see what Dr. Ayman has to say. Dr. Ayman, what did you think of that?
I think there is something we don't understand in our practice. There is many case report that as show Noor. I think there is many things to discuss. What?
Noor.
I think there is many things to discover in in the future for the mechanism of auricular ventricular block. Maybe there is other methods of stimulation to to use in the future. And there is I think many tools to screening bradycardia with smartwatch and other tools. I think in the future there is a work to do to understand some mechanism actually not understanding.
I think metabolically, I think the metabolism of the body has a lot to do with it. Like ions and things we still don't comprehend properly. I think that will help a lot. Plus, there's very different pathways that we don't understand, and we have no clue. We're clueless as to what's going on.
Yes, I think so.
Maybe I can add something here. This is Dr. Zain from Tunisia. Can I add something here?
Who's speaking?
Dr. Zain from Tunisia.
Hi, where are you? Show us yourself, please. We missed you.
Okay, so, thank you. So actually, do you hear me well?
Yes.
Okay, so just I wanted to add something. All these cases are like old cases, and I maybe I can say that I might doubt the equity of this case, actually, of these cases, because not all the cases are real cases, first. And second, maybe there's some kind of bias, like, I don't know, for the acromegaly, maybe it was the age also. So we are not really sure that it is related to the hormone.
Zainab, we don't.
Do you hear me again now?
Yes.
I lost connections, actually. So I was saying that all these cases are really old, and I'm not sure if they are really accurate. So especially for the acromegaly, I believe maybe the age was another factor in that case. And just like to say that we cannot really say that these, I mean, we will, I mean, do you hear me well, or it's not good?
Zainab, I agree with you, but I think in the future using screening bradycardia like tools validate in atrial fibrillation can help us to understand and to say if these cases are not accurate and precise case, are old case, or if there is other mechanism we don't understand until nowadays.
Yeah, for sure, for sure.
I'm gonna share an article with you on WhatsApp after the session is over. I'd like your feedback on it, inshallah. Okay, so are you ready? Yemen, are you ready?
Yes, we are ready.
Yemen.
Yes, we are ready.
Okay, go.
I will share.
Emergency medicine to manage patient with bradycardia. Bradycardia is slow heartbeat condition, typically less than 50 beats per minute. Bradycardia with pulse presence, we must do open airway, maintain and protect breathing and circulation. Monitor the patient vital sign, including heart rate, blood pressure, and oxygen saturation, and identify IFS, intravenous access, and identify the causes of bradycardia, including hypoxia, hypovolemia, acidosis, toxin, cardiac issue, looks like heart block, and other factors. If patient with good
You need to change your
perfusion,
slides. We are not seeing your changing. The first slide only disappears.
okay? If patient, continue.
واصلك.
If patient with good perfusion, we go to observe and monitoring. Is the bradycardia causing the symptoms or some other else? Persistent bradycardia causing hypotension, acute altered mental states, signs of shock, ischemic chest discomfort, or acute heart failure as symptoms for persistent bradycardia. If the patient is with poor perfusion, give atropine, or if not response, go to transcatheters, transcutaneous passing TCP, or dopamine IV infusion, epinephrine IV infusion. Atropine is muscarinic receptor antagonist that is used to inhibit the effect excessive vagal activation on the heart, which is manifested as sinus bradycardia and IV nodal block. Atropine can temporarily revert sinus bradycardia to a normal sinus rate and reverse IV nodal blocks by removing vagal tone. Atropine as mechanism as muscarinic receptors is blockage vagal nerve by blockage the acetylcholine to contact with M receptors and increase heart rate and improve the bradycardia. The dose of the atropine, if the patient has symptomatic bradycardia with poor perfusion, consider atropine or transcutaneous passing. The typical essential dose for adults is 0.5 milligram IV, which can be repeated every 3 to 5 minutes up to 3 milligrams. And another drugs you can use is dopamine. The mechanism of dopamine by improve heart rate and improve cardiac pumping is beta-1 receptor stimulator and beta and alpha-1 receptors in blood vessels and increase vasoconstriction in the periphery. And in the renal, increase renal blood flow by D1 receptor and B1 receptors. And another drug is epinephrine. The mechanism of epinephrine alpha-1 receptors in the peripheral vascular, and the mechanism is increased systemic vascular resistance and aortic diastolic pressure, right atrial minus right atrial pressure, and to improve coronary perfusion pressures and improve coronary flow. The dose of dopamine and epinephrine in the emergency, epinephrine and dopamine are second-line drugs for symptomatic bradycardia. If atropine is ineffective or not indicated, consider using medication like dopamine or epinephrine to increase heart rate and improve cardiac output. Dopamine can be infusion to 20 micrograms per kg per minute. Epinephrine can be administered at 2 until 10 microgram per minute. And the temporary pacemaker that's used bipolar epicardial and bipolar, and this is external passing. A temporary passing in cases of severe bradycardia and responsive to medication, or if the patient remain unstable, temporary transcutaneous passing may be necessary. And if can't file this, consult with cardiologist or specialist. If the bradycardia is related to underlying cardiac condition, disorder looks like heart block, consult with cardiologist or electrophysiologist for further evaluation and potential permanent pacemakers. And we can treat it, and we must look for contributed causing of bradycardia and treat it. Looks like hypopholemia, hypoxia, hydrogen ion excess, acidosis, hypothermia, treated hypocalcemia, and treated toxins, tamponade, tension, pneumothorax, and the thrombosis, pulmonary embolism, thrombosis, myocardial infusion, and the trauma. This is the guideline of American Heart Association as the beginning and the conclusion of the everything. Thank you.
Thank you very much. Okay, for the sake of time, Egypt.
Are you seeing the PowerPoint? Are you hearing me well?
Yeah, it's okay.
Okay, and
Yes,
what about PowerPoint?
Yes, we can see the slide. We can hear you and we can see the slide.
Okay. I will go fast with a solo presentation with a complete heart block. As all we know is that third-degree heart block actually refers to a heart block with abnormal heart rhythm, a defect in the cardiac conduction system, leading to a complete dissociation between the atria and ventricles. We have a criteria or some of characters of PV block. Can see regular RR interval, and the link apparent dissociation or a relation between the B wave and the QRS complex.
Can
Usually,
you
what?
Mute yourself. صوت
صوت ماله.
Yes, فاتحين
كده كويس طيب؟
Can you please mute
Are you
the
making
second
it?
mic?
Is it okay?
Yes,
Hello?
continue.
Okay. More B waves are present. It's for sure because B wave not conducted to the complex. So more B waves than QRS. Here is an example of a complete heart block as we see in the ECG. We look for the dissociation, the regular RR and the regular BB interval, but some B is not conducted to the QRS, so makes this dissociation. Third degree heart block sometimes can be patient present with many symptoms, and sometimes the symptom may be vague and maybe not related to the fatigue or dizziness only, but sometimes patient come with chest pain or exercise intolerance. So we should take care of the presentation well patients with complete heart block, especially if he is old age. The differential diagnosis that we should put in our consideration in the diagnostic consideration of complete heart block is the ischemia should be in the differential diagnosis for patient with high-grade AV block.
Excuse me.
And it can be, for sure, it can be diagnosed through the ECG and the cardiac enzymes. Other differential diagnosis that should be considered is like some abnormalities in our ECG, like junctional risk, myocardial infarction, as has been mentioned, myocarditis, or second degree AV block, or the sinus bradycardia. Management, for sure, patient with complete heart block should be managed at emergency department, and should we establish patient well for the vital signs. Sometimes some patient need an oxygen, maintenance of IV line, frequent monitoring of blood pressure, and continuous cardiac monitoring through an monitoring ECG. Transcutaneous pacing debates should be applied. And lastly, the pacemaker, as we know, it is a class 1 recommendation for the documented complete heart block. Pacemaker, it's very mandatory unless the heart block is due to medication or to a metabolic cause. Thank you.
Thank you, Dr. Mario. You weren't sharing your screen. Okay, we've come to the conclusion of today. I just wanted to ask. Everybody. There's a picture on there. Can you read it, please? And we'd like Dr. Zainab's opinion. Share it.
Okay, I'm opening actually. So there's the article, and I'm opening it on my laptop.
The summary of the article, actually. It's just a summary.
This is the okay. This is the summary then.
Those points. Yeah.
Okay.
What do you think? Can you give us a comment on those items?
Okay. I'm just reading.
Take your time. we missed you, really, we did. Can we see your picture or your,
Yeah, I can.
are you at home? Okay.
No, actually, I'm at work, so I'm gonna just open my camera then. You see me?
Yes, there you are.
The lighting, yeah, the lighting is better.
Wallahi.
Thank you.
We did, wallahi, we missed you.
Actually, it's just, today we had like quite a complex procedure in the EP lab, so this is why I
You're
couldn't.
busy.
So now I'm gonna go back to the summary. I'm gonna read it. Okay. So this is like opening a new window to a new type of research.
Just like glial cells have a direct physical connection with cells in the conduction system of the heart. That was astounding for me. Our nerve cells are in communication with our pacemakers in the heart.
Yeah, this is, I mean, for me, it won't be strange. I mean, it's quite a concept that there are some, especially group working, I believe from Israel. Yeah, Israel, they are working on that. They are trying to make some kind of biological pacemaker. So instead of implanting the pacemaker that we have now, the hardware, they are working on that. And I believe they are using something like that, actually. This is the concept for them, if I'm not mistaken. So this is for the glial cells. And for the immune part, yeah. I would believe
that on the other side of the heart, yeah, plasma cells that release antibodies to prevent infections from the lungs. That was also interesting. And a cellular niche was also identified that may serve as an early indicator of heart failure. They don't even know it's there. It's just a space, a niche, and they don't know what's in it. So it was.
This is really interesting. So I'll show you. So the problem with that is that, well, in Tunisia, not I don't know in other countries, but in Tunisia we don't really have the support to do such research. We can start, but it will almost stop midway just because of funding and everything. But yeah.
Well, it was great seeing you again, and I hope we see you every single time. We love having you with us, Dr. Zainab.
Not everything at time, but I will try. Yes.
Okay, that would be great. We love having you. I'd like to thank everybody, and it was a nice day. Of course, we had problems with the audiovisual. I hope we can solve that somehow. We'll get there, inshallah. Once in a lifetime, we'll get there, inshallah. And we'll see you again, inshallah, Dr. Zainab. Next Wednesday is
next
Wednesday is off. The Wednesday after that, inshallah.
Yeah. Okay.
Okay.
Thank you.
Thank you, everyone. Thank you, everybody. Bye. Goodbye.
Dr. Mona.
Yes.
We just had a little question regarding hypertension module, because on the WhatsApp table that you sent us, it's written the 3rd of August, the 3rd of August. I think it's just a typo, right?
3rd of August?
Because the 3rd of August is a Saturday. I think it's a typo. We just wanted to make sure.
Oh, okay.
So it will be the 24th? The 24th?
Yeah, probably. The next one.
Okay, I just wanted to make sure.
I'm merging the Tunisian team with the Egyptian team, so that way you can get a chance to relax a little bit. I think you're all stressed out, both of you, actually, the Egyptians and the Tunisians. Yes. And I'm also giving Yemen a chance to work, have everybody working instead of really working every other week. They're going to be working every week, just like you are. So you're okay with that? Great. And I'm happy that you're only 4, because now you get to be patient and doctor and switch. Okay, so there's no problem there, inshallah.
So it will be for all sessions, Tunisian with Egyptian.
Yeah, I think that would be
okay,
best for
great.
everybody, for the
Great.
MDs and for everyone. Yeah, yeah. We'll
yeah.
switch the roles periodically. Every week,
Sorry,
so.
Dr. Mona, I sent you.
You're doing a great job, by the way.
Thank you. I sent you a private message on WhatsApp if you can check it.
Okay, now or afterwards?
Oh, whenever you like, just
Sure.
yes,
Okay.
it's a little bit personal.
Okay.
Okay, so
Okay.
about next week, it will
okay,
be
later then.
8:30 or 8 o'clock, because every time you get
Next
here,
week, we don't have
early.
anything next week. It'll be the week afterwards.
Okay,
Next week, there's nothing.
next week.
Nothing next week.
Because we have some kind of holiday here. I'm not sure. I don't.
Oh,
Great,
okay,
we
okay.
like holidays. We love holidays.
There's a holiday here, so we won't be working. The Wednesday after that, we'll gather up
Okay,
our
great.
camp again. Case submission. Does everybody understand Yemeni? I know you do. Yemen, are you still here? Yemen, do you understand what case submission is?
Yes, yes, yes. We will manage it and send for you.
Do you understand it? Hmm?
Yes, yes.
Do you understand
will-
what case submission is? Because I was asked a question about. Yes?
Yes, yes.
The presentation we present during